We would like to thank the guest editors for inviting us to contribute to this special issue of the Annals of Cardiothoracic Surgery with our review entitled Barrett's Esophagus, Best Practices for Treatment and Post-Treatment Surveillance. This presentation will cover screening for Barrett's esophagus, surveillance in Barrett's esophagus, advanced endoscopic imaging, chemoprevention, endoscopic therapy for Barrett's esophagus, and post-treatment surveillance. Barrett's esophagus is the only known precursor lesion of esophageal adenocarcinoma. Barrett's is primarily a disease of the Western world, and risk factors for Barrett's esophagus include older age, male sex, Caucasian race, GERD symptoms, central abdominal obesity, and possibly tobacco smoking, and these risk factors mirror the risk factors for esophageal adenocarcinoma. Endoscopically, Barrett's esophagus appears as an area of so-called salmon-colored mucosa in the distal esophagus, as outlined in the image over here. Generally, there is a circumferential component of Barrett's esophagus in the distal esophagus, and moving proximally, there are usually some tongues or island that extend proximally beyond the circumferential Barrett's esophagus. However, the endoscopic appearance alone is not sufficient to make a diagnosis of Barrett's esophagus, and biopsies showing intestinal metaplasia are required in order to make a diagnosis. It is believed that most, if not all, esophageal adenocarcinoma develops from areas of BE, and patients with BE are at increased risk of developing esophageal adenocarcinoma compared to patients without BE. The diagnosis of esophageal adenocarcinoma is typically made at an advanced stage and carries a poor prognosis with a 5-year survival of only about 17%. Because of that, there has been a significant focus on prevention and early detection, primarily by screening for BE, surveillance in BE, and treatment of dysplastic BE. When it comes to screening for Barrett's esophagus, screening at a population-wide level is not cost-effective. However, screening is recommended in high-risk individuals. This includes men with chronic and/or frequent GERD symptoms and 2 or more risk factors for Barrett's esophagus or esophageal adenocarcinoma, including age greater than 50, Caucasian race, central obesity, history of tobacco smoking, and a family history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. There are some limitations when it comes to screening for Barrett's esophagus. Risk-based screening may miss a considerable proportion of patients with BE. It has been shown that at least 40% of patients who are ultimately diagnosed with esophageal adenocarcinoma reported no history of typical GERD symptoms. And because we only screen in patients who generally have symptomatic GERD, that means we may be missing a large chunk of patients who actually have Barrett's esophagus with our current screening recommendations. In addition, a systematic review of 12 studies published between 1988 and 1999 showed that only 4.7% of patients undergoing surgery for esophageal adenocarcinoma carried a prior diagnosis of BE. So there is still a lot of work to be done with regards to optimizing our strategies for screening patients with Barrett's esophagus. Moving on to surveillance. When it comes to surveillance in Barrett's esophagus, the goal is to detect dysplasia or early esophageal adenocarcinoma so that curative treatment can be offered prior to the development of advanced esophageal adenocarcinoma. There is some controversy with regards to the efficacy of surveillance in Barrett's esophagus, but generally observational studies have shown improved outcomes in patients with esophageal adenocarcinoma who had been undergoing surveillance for Barrett's esophagus as opposed to those without Barrett's surveillance. Some of the best evidence for this comes from a cohort study of nearly 30,000 veterans with Barrett's esophagus, and the results of this study showed that patients that were diagnosed with esophageal adenocarcinoma as part of a Barrett's esophagus surveillance program were more likely to be diagnosed with early-stage disease, had improved survival, and lower cancer-related mortality compared with patients diagnosed with esophageal adenocarcinoma who were not part of a Barrett's surveillance program. In terms of how we survey patients with Barrett's esophagus, generally surveillance involves careful endoscopy, usually with high-definition white light endoscopy and sometimes optical chromoendoscopy, with 4-quadrant biopsies every 1 to 2 centimeters along the length of Barrett's esophagus, and this is known as the Seattle protocol. If the biopsies show no dysplasia, endoscopic surveillance is recommended every 3 to 5 years. If the biopsies come back showing indefinite for dysplasia, It is then recommended to maximize acid suppression and repeat endoscopy in 3 to 6 months. If the repeat endoscopy shows still indefinite for dysplasia, then we repeat the endoscopy in 1 year. If there is a change in dysplasia grade, then we follow the pathway for the new dysplasia grade. If the biopsies show low-grade dysplasia, most of the evidence now suggests that we should offer endoscopic therapy to patients with low-grade dysplasia. However, screening or surveillance is an alternative, and in patients who opt for surveillance, that should be done every 6 to 12 months. If biopsies show high-grade dysplasia, there is overwhelming evidence that these patients should undergo endoscopic therapy, and these patients should all be offered endoscopic therapy as a first-line treatment. While surveillance of Barrett's esophagus appears to be beneficial, the current surveillance strategies are inefficient and include risks of endoscopy and sedation, the possibility of missed lesions, and complications from curative treatment. So there are many efforts to improve surveillance which are ongoing, and part of this involves the use of advanced imaging in order to improve our surveillance of Barrett's esophagus. So we know that the Seattle protocol, which is our current systematic 4-quadrant biopsy protocol, is relatively inefficient and has low diagnostic yield for neoplasia. Because of that, there has been much interest in studying the use of endoscopic advanced imaging techniques in order to improve the diagnostic yield and value of Barrett's esophagus surveillance. And the goal or the idea is to move away from these blind, random biopsies to imaging-directed targeted biopsies, where we use advanced imaging modalities to examine the esophagus, image the esophagus, and help identify areas that harbor dysplasia or early cancer and target our biopsies at those specific areas rather than take random blind biopsies. So how do we know if an advanced imaging technology is good enough to stop random biopsies? So in 2012, the ASGE Technology Committee issued this PIVI statement stating that an imaging technology with targeted biopsies should have a per-patient sensitivity of at least 90% and a negative predictive value of at least 98% for detecting high-grade dysplasia or early esophageal adenocarcinoma compared with the current standard protocol, and the imaging technology should have a specificity that is sufficiently high, at least 80%, to allow reduction in the number of biopsies compared with random biopsies. So now what I'm going to do is I'm going to go ahead and explain the different advanced imaging modalities that are available, and at the very end I will summarize the data in a comparative nature and see which of the imaging modalities are able to meet these criteria. So the earliest advanced imaging modality is traditional or dye-based chromoendoscopy, and this involves the use of dyes or chemicals which are applied typically with an endoscopic spray catheter onto the mucosa to enhance the visualization of the subtle mucosal and microvascular patterns. The most commonly used dyes are methylene blue, indigo carmine, and acetic acid. Dye-based chromoendoscopy has not gained widespread clinical use because it is considered tedious and time-consuming, it's inhomogeneous, and there is lack of separate reimbursement for chromoendoscopy, and because of that, it has not been widely used. On the other hand, electronic or optical chromoendoscopy is much more commonly used. This technology uses filters within the endoscope to emit light at certain wavelengths and/or specialized computer processing technology to enhance the visualization of the mucosal surface. It is much easier to use than dye-based chromoendoscopy. It is less tedious and it can be turned on and off instantaneously just by a push of a button on the handle of the endoscope. There are 3 types of optical or electronic chromoendoscopy that are commercially available, and each one is depending on the brand of the endoscope that you're using. So if you're using Olympus equipment, the optical chromoendoscopy technology is called narrowband imaging, or NBI. This happens to be the one that's most widely used and studied, and over here you can see an image of Barrett's esophagus in NBI. If you're using Pentax equipment, their technology is called iScan, and for Fujinon equipment, it would be Fujinon Intelligent Color Enhancement, or FICE. Confocal laser endomicroscopy is a different type of advanced imaging technology, and this is something that allows for so-called optical biopsies, because This allows for in vivo microscopic level magnification at around 1,000 times magnification for evaluation of the epithelium. And in this image, you're able to see a image of Barrett's esophagus imaged with confocal laser endomicroscopy. CLE requires the administration of a fluorescent agent, typically intravenous fluorescein, and it's not widely used due to the immense costs involved and the need for intravenous contrast. So going back to our criteria, what is needed to be good enough to stop random biopsies? We said it would be a sensitivity of at least 90%, specificity of at least 80%, and a negative predictive value of at least 98%. And in 2016, the ASGA Technology Committee published a meta-analysis looking to see which of these modalities were able to meet these thresholds. And as you can see here, acetic acid, chromoendoscopy, NBI, and endoscope-based CLE were all able to meet the thresholds. The thresholds were not met by methylene blue chromoendoscopy, indigo carmine chromoendoscopy, or probe-based confocal laser endomicroscopy. Keep in mind that these results are achieved typically in expert hands at advanced centers. With regards to NBI and confocal laser endomicroscopy, these are usually high confidence readings. And with NBI, most of these studies were used with NBI with magnification, which is not available everywhere. So while these results are promising, it is probably not ready to be adopted generally in the community. Moving on to chemoprevention. So given the poor prognosis of esophageal adenocarcinoma after diagnosis, there's been great interest in studying preventive strategies. And the goal of chemoprevention in Barrett's esophagus is to avoid the initiation or progression of dysplasia and/or inhibit the invasion of dysplastic epithelial cells across the basement membrane. And the most widely studied classes of drugs are acid suppressive agents, non-steroidal anti-inflammatory drugs, and statins. Proton pump inhibitors, or PPIs, have shown mixed results, but most studies from prospective and retrospective cohort studies have concluded that PPIs may be protective in patients with Barrett's esophagus. A systematic review and meta-analysis of 7 observational studies showed that PPI use was associated with a 71% risk reduction of esophageal adenocarcinoma or high-grade dysplasia in individuals with Barrett's esophagus, with a trend towards a dose-response relationship. Moving on to NSAIDs, a pooled analysis of 6 population-based studies showed that use of NSAIDs, including aspirin, significantly reduced the risk of development of esophageal adenocarcinoma. However, a separate randomized trial studying the use of celecoxib in chemoprevention actually showed no benefit, and another population-based case control study of low-dose aspirin or NSAIDs published in 2015 was also unable to show a reduction in risk of high-grade dysplasia and EAC in patients with Barrett's esophagus. So the use of NSAIDs exclusively for the prevention of esophageal adenocarcinoma in patients with BE cannot be recommended at this time. Statins have also been studied as a chemopreventive agent in Barrett's esophagus. A meta-analysis of 13 observational studies reported a significant reduction, about 41%, in the risk of esophageal adenocarcinoma in patients with known Barrett's esophagus. And a nested case control study of patients with Barrett's esophagus showed an inverse association between statin use and the development of esophageal adenocarcinoma, with a greater effect with higher doses and longer duration of use. But despite these promising results, the use of statins for the sole purpose of chemoprevention in Barrett's esophagus is still not routinely recommended. Moving on to endoscopic therapy for Barrett's esophagus. So, endoscopic eradication therapy has really transformed the way that we manage dysplastic Barrett's esophagus and early esophageal adenocarcinoma, mainly T1A or intramucosal cancer, and has virtually eliminated the need for radical esophageal surgery in the majority of these patients. Endoscopic eradication therapy is recommended in patients with T1A esophageal adenocarcinoma, Barrett's with confirmed high-grade dysplasia, Barrett's with confirmed low-grade dysplasia, but endoscopic therapy is not recommended in patients with non-dysplastic Barrett's esophagus, and those patients should undergo surveillance alone. There are two main modalities of endoscopic eradication therapy, and these are endoscopic ablation and endoscopic resection. Endoscopic eradication therapy is most successful with a multimodality approach which combines endoscopic resection of visible or nodular disease followed by mucosal ablation of flat Barrett's esophagus. Radiofrequency ablation is the most commonly used method of ablation in Barrett's esophagus, and it uses a bipolar electrode array and a generator to create a thermal injury of limited depth from 500 to 1,000 microns. There are many different RFA catheters that are used. This over here is the Barrett 360 RFA balloon catheter. This is generally used to treat circumferential Barrett's esophagus. This is the Barrett 90 RFA focal catheter. This is generally used to treat isolated tongues or islands of Barrett's esophagus, and this can be outlined here. And there are also other catheters that can be used, including the RFA 60 catheter, which is also a focal ablation catheter with a smaller area. And there is also the channel RFA catheter, which can be introduced through the endoscope working channel. The best evidence for RFA in Barrett's esophagus comes from the Dysplasia Trial, and this was a landmark study published in 2009 in the New England Journal of Medicine. This was a randomized sham-controlled trial of RFA for Barrett's esophagus with either low-grade dysplasia or high-grade dysplasia. And you could see that in the low-grade dysplasia group, complete eradication of dysplasia was achieved in 90.5% of patients in the ablation arm compared to 22.7% of patients in the sham arm. In high-grade dysplasia, complete eradication of dysplasia was achieved in 81% of patients in the ablation arm compared to 19% of patients in the sham arm. And when looking at complete eradication of intestinal metaplasia or CEIM, that was achieved in 77.4% of patients in the RFA arm compared to 2.3% of patients in the sham arm. And all of these results were statistically significant. There are some complications associated with RFA. Chest pain RFA is fairly common and occurs in about 25 to 50% of patients, but is usually self-limited and typically lasts for only 3 to 4 days. The most common serious complication is esophageal stricture formation, which can occur in up to 8% of cases, but these can always usually be successfully managed with endoscopic dilation. Bleeding and perforation are quite rare with RFA alone, but can be more common when EMR is performed concurrently with RFA, and there have been no procedure-related deaths reported in relation to RFA. Cryotherapy is a different type of ablative modality and involves the application of extremely cold temperatures in order to achieve tissue injury, disruption of cell membranes, and denaturation of proteins. Liquid nitrogen spray cryotherapy is the most studied type of cryotherapy. In a retrospective cohort study of 96 patients with Barrett's esophagus with high-grade dysplasia, it was shown that 97% had complete eradication of high-grade dysplasia, 87% had complete eradication of dysplasia, and 57% had complete eradication of intestinal metaplasia. Another study of 32 patients designed to assess long-term safety and efficacy for Barrett's esophagus with high-grade dysplasia demonstrated 100% complete eradication of high-grade dysplasia and 84% complete eradication of intestinal metaplasia at 2-year follow-up, with recurrent high-grade dysplasia noted in 16% of patients. In a prospective cohort study of 80 patients with Barrett's with low-grade dysplasia or high-grade dysplasia, it was shown that complete eradication of dysplasia was achieved in 91% of patients with low-grade dysplasia and 81% of patients with high-grade dysplasia, while complete eradication of intestinal metaplasia was achieved in 61% of patients with low-grade dysplasia and 65% of patients with high-grade dysplasia. There is also a new balloon-based through-the-scope focal cryoablation device that has been developed to treat Barrett's esophagus, and clinical trials of the safety and efficacy of this device are ongoing. Endoscopic resection is typically recommended for visible lesions, either nodular lesions or flat lesions with mucosal irregularity in Barrett's esophagus. This allows for definitive histologic analysis with accurate depth of invasion information, which can provide important information for staging and can also often be curative. There are two types of endoscopic resection, and these are endoscopic mucosal resection, or EMR, and endoscopic submucosal dissection, or ESD. Both of these will be discussed in detail elsewhere in this issue. Moving on to post-treatment surveillance. Recurrence of Barrett's esophagus following complete eradication of intestinal metaplasia is not uncommon. A meta-analysis of 41 studies published in 2016 reported that the pooled incidence of Barrett's recurrence with or without dysplasia was 9.5% per year, with rates in individual studies ranging from 0.9% to 28.8%. It most often recurs as non-dysplastic Barrett's esophagus, and the vast majority of recurrences were successfully treated endoscopically. It's been shown that increasing age and length of Barrett's esophagus were found to be predictors of recurrence. Continued endoscopic surveillance after treatment for Barrett's esophagus is essential due to the documented risk of recurrence. For patients treated for high-grade dysplasia, it is recommended they receive surveillance endoscopy every 3 months for the first year following complete eradication of intestinal metaplasia, every 6 months in the second year, and then annually. For patients treated for low-grade dysplasia, they should receive surveillance endoscopy every 6 months in the first year following complete eradication of intestinal metaplasia and annually thereafter. Targeted biopsies of any visible abnormalities should be obtained in addition to random 4-quadrant biopsies from the entire length of the prior Barrett segment, which should have been previously measured at the time of diagnosis. One concern in the post-treatment surveillance period in Barrett's esophagus is subsquamous intestinal metaplasia, or SSIM. This is also commonly referred to as buried Barrett's or buried glands, and is defined as the presence of Barrett's metaplasia beneath an intact layer of squamous epithelium. The initial concerns have been that esophageal adenocarcinoma can develop from this subsquamous intestinal metaplasia below the squamous mucosa, and that you could get esophageal adenocarcinoma from an area that cannot be seen. And while this has been described at the case report level, the early fears that buried Barrett's may be caused by ablation and may actually increase the risk of developing esophageal adenocarcinoma have not been corroborated. Cohort studies have actually shown that SSIM often presents prior to ablation in up to 38% of patients, and it appears that SSIM may actually decrease following ablation of Barrett's esophagus. A randomized sham control trial of RFA in Barrett's showed that there was presence of SSIM in 25% of cases prior to ablation, and this decreased to 5% 12 months after ablation. And in a 2015 study from the US RFA registry, it was shown that SSIM was associated with increased risk of esophageal adenocarcinoma, but all subsquamous cancer occurred prior to complete eradication of intestinal metaplasia. After CEIM, SSIM was much less common, and this suggests that the RFA actually probably eradicates SSIM and prevents subsquamous cancers. So in conclusion, endoscopic therapy has become an established standard of care for patients with dysplastic Barrett's esophagus. Endoscopic ablation is effective at achieving complete eradication of dysplasia and complete eradication of intestinal metaplasia in most patients, and RFA is the most studied modality and has been shown to be safe and effective in most patients. Due to the remaining and unpredictable risk of recurrence, continued endoscopic surveillance after ablation treatment is required, and most recurrences are amenable to endoscopic treatment with timely detection. Future research should focus on the role of advanced imaging and biomarkers in screening and surveillance both pre- and post-ablative therapy.